Hello, welcome again. Today we're going to be talking about another in our series of clues to classification for beginning trainees dealing with ovarian tumors. This is part 3, and today we're going to be focusing on the endometrioid tumors as well as transitional tumors, and we'll touch on clear cell as well. So we've covered in part 1 the serous tumors, in part 2 the mucinous tumors, and today we're going to try to wrap up the rest of these common epithelial tumors. So to begin with, endometrioid tumors have a couple of different categories. We have, of course, endometrioid adenofibromas that would be in the benign category, and of course endometriotic cysts or endometriosis, which can be the site for neoplastic transformations or pre-neoplasia. We also have these borderline tumors that may or may not have microinvasion. So these would be more adenofibroma type lesions with sort of an EIN type of appearance to the glandular component. And then finally, we do encounter frank endometrioid carcinomas. So let's just start to think about this, why we would see this. Endometriosis is really quite common, as are the cystic changes with endometriosis in the ovary. The other thing that can happen is that we can have synchronous uterine and ovarian tumors that can be observed with both low and sometimes high-grade cancers in each or both. But by and large, most endometrioid tumors are stage 1, confined to the ovary. But when we start talking about synchronous primaries, or possibly metastasis from a uterine primary to the ovary, we need to start thinking about some of those complex questions, and we've covered some of that in prior videos. So let's take a look at an example of the low end of the spectrum. Here we see fragments of ovary, and we see a little bit of sort of adenofibromatous type tissue. Some glandular tissues here and a dilated cystic space. So let's take a look at higher magnification and see what we find here. This would be the pattern usually associated with an adenofibroma. And then what we would want to define is this serous, mucinous, clear cell, endometrioid, or transitional? Well, we see some sort of branching type glands, a little bit of cystic dilatation here. But as we look at this epithelium, it's a little bit more columnar, more lush than typical serous neoplasms might be. We don't see stroma here, but we also, even though we're seeing a little tufting here, I don't think that's ciliated surface, which would qualify it to count as a serous neoplasm. Sometimes you can get secretory changes in these. Sometimes you'll also have residual germ cells, or you may have areas of luteinization in the stroma. Here's another area of this neoplasm, and we see this very hyalinized, almost papillary type lesion. So why is this not a serous adenofibroma? Well, again, it's because the type of epithelium that we're dealing with is endometrioid, rather than serous. Now, is that an important distinction in a benign lesion? No. If you call this a serous adenofibroma, the patient is not going to come after you and sue you or make a problem. Certainly, there's not a great deal of difference in behavior with these lesions, and so that also will not be a problem. But you should be aware that they can be seen. Particularly, you'd want to think about it if you have a situation where you have associated endometriosis, which is probably what we're seeing right here. We can see this condensed stroma, the loose columnar glands. It's not very proliferative, so this is probably a postmenopausal patient. And so finding associated endometriosis in this setting would certainly go a long way towards the thinking of endometrioid adenofibroma. Look at some other tumors here. Here again, we see a dense fibrous area, some cystic changes, and then a little bit more complex epithelium here. So looking first at this component, we see that we again have a nice tall columnar type epithelium, no significant endometrioid type stroma, maybe a little bit of condensed stroma here, a little tufting of the epithelium, but no cilia per se. We see here an area of old hemorrhage and maybe necrosis with cholesterol cleft formation. And then looking at these other areas, again, we see a little bit of endometrioid type tissue here, maybe some stromal type tissue. And then look here, we have a little bit of atypical proliferative pattern, glandular crowding, moving into the hyperplastic atypical hyperplasia realm with some papillarity and architectural complexity. Here's more of that. Again, we see some intervening stroma, but we're seeing tufting of the epithelium. So if and why is this not atypical hyperplasia? Well, in endometriosis, because the stroma is not an endometriotic stroma. So this is occurring in an adenofibroma background, and we're getting atypical hyperplasia type of changes, glandular crowding, a little bit of columnar cell change. But again, we're not having the necrosis or rounding up of the nuclei into more carcinomatous features. So this is a nice example of a borderline endometrioid type tumor. And here we see even a little bit of sort of squamous metaplasia that again tells us that this is endometrioid type, and its occurrence in an adenofibromatous setting fits nicely into that category of borderline endometrioid adenofibroma. These lesions would get some follow-up and monitoring to make sure that they did not have implants or have atypical features elsewhere. And so that's an important distinction to make. Going a little bit further, here we can see, again, fibromatous background and more complexity of the epithelium with some branching of the glands. A little bit of stroma-like tissue here, also some squamous metaplasia. Notice, however, that we don't have a lot of third and fourth degree branching. We don't have confluent or labyrinthine glands. So again, this is something that would probably fit best into the borderline or low malignant potential category of endometrioid tumors. And so getting this kind of image fixed in your mind is very helpful to sort of see where the center points should be as you begin to make the diagnosis. And again, why is this not endometriosis with atypical hyperplasia and squamous metaplasia? Well, because it's occurring in this fibromatous background of randomly scattered tissue fragments. It's not a endometriotic cyst that has developed atypical hyperplasia. Another example, another section, I think, from the same case. And here we can see less of the proliferative pattern and more of this cystic adenofibromatous component that is quite clearly low-grade or benign, but admixed with these areas where we get a little bit more complexity, more epithelial cell volume, some stromal changes, some squamous metaplasia, and a little bit of stratification of the nuclei, maybe a minimal degree of loss of polarity, and so forth. Here we can again see more of the squamous metaplasia in this lesion. So these are nice examples of borderline endometrioid adenofibromatous type lesions with areas of clearly benign functionality and areas where we're getting more proliferative and atypical changes compatible with that borderline designation. One final example, again, just to give you this picture, benign areas here, borderline areas here. So not unlike some of our other borderline tumors where we can have both very benign areas and other areas where we get more proliferation. Here we're seeing much more of this squamous morular metaplasia in these glands and a more complex variable architecture. Looking a little further, again, some closely spaced glands like we would think in EIN, greater than 50% in a localized area like this, putting it into that kind of category of glandostroma being altered and perturbed. And here we can see that sometimes you can get a little bit of this papillarity that we would associate with serous-type tumors, but here we can clearly see that it's endometrioid because we've got squamous metaplasia. Now, another ovarian tumor, we can see here's ovarian parenchyma over here, corpora albicans. This is not a difficult case. This is clearly mostly solid tumor with epithelium, and we could debate and question whether the classification of this tumor as serous or endometrioid is appropriate. But we can see that there's a nice glandular component to it as well as solid growth. So this would fit nicely into the grade 2 or 3 endometrioid carcinomas that can arise in the ovary. Mostly solid growth here, probably greater than 50%. So I think classifying this as grade 3 would be most appropriate. Although we do have still a lot of small glandular structures in many areas as well. The nuclei are still more in the grade 2 category as well. So that's not a hard case, but just to be contrasting for you. Here's another case, again, an ovarian lesion and mostly solid growth. Apologize for the poor scanning functionality here. We can see areas of necrosis. We see some solid growth, some glandular growth, mostly columnar cells. If you were questioning, you could certainly do P53 and WT1 and various other markers for serous versus endometrioid, but this would certainly stain with markers characteristic of endometrioid adenocarcinoma. Probably not going to find much squamous metaplasia in this high-grade lesion as you do with the lower-grade lesions. But if you do, that's certainly very helpful as a marker for endometrioid differentiation. Another tumor here seen within a cystic space with some hemorrhage. As we look at the wall here, we can see some residual columnar epithelium. This actually may be fallopian tube because that looks like a muscular wall there. And here we can see areas of solid growth, some glandular sieve-like patterns, but some of this solid growth is a little bit more squamous in character. Nice sieve-like pattern, grade 2, and then here we see a little bit increased cellular size and cytoplasm, a little suggestion of squamous differentiation, some necrotic debris, maybe some keratinization there. So again, another endometrioid carcinoma, not a difficult diagnosis, but differentiating it from serous-type tumors or other neoplasms. Fatwa might be considered in some circumstances. Usually helped if you find areas like this that look like squamous morular differentiation. So let's move on to transitional tumors. In this camp, we've got several prominent actors, but none of them are very common. The Brenner tumor is a transitional adenofibroma, and then it can come in a borderline variant as well as malignant variants, where you have malignant urothelial-like epithelium, but still a adenofibromatous type stroma, and then a conventional transitional cell carcinoma where the stroma has largely disappeared and you're left with pure transitional cell carcinoma. So these are not commonly encountered, and that's part of the reason I don't have very many in my digital collection. In fact, I only have the benign variants of these lesions. Oftentimes, these are just incidentally discovered, like this example right here. It's pretty tiny, just a slight thickening of the cortex, but you can see that we have kind of a clown-like appearance here with a couple of eyeballs staring back at us from behind his ski mask. This is a characteristic transitional type of epithelium. If we look closely, we can see some nuclear grooves, very bland appearing nuclei, a slight surface flattening around these lumina if they're present. No worrisome features here, and then a surrounding storiform or fibrotic stroma that is a little distinct from the rest of the ovarian stroma, gives you this appearance. So a completely benign little ditzel in most cases, as I said, most often incidentally discovered. Let's take a look at another one. Here we see a dense fibrotic area here. Again, little islands of epithelium. As we look at these, we see they're sort of irregularly shaped, rounded, may or may not have little lumina in a few of them, like we did in the other case. Again, we see the sort of streaming pattern of the nuclei, some clearing of the cytoplasm, prominent cytoplasmic borders, nuclear grooves. Well, you don't see them well in this slightly thick section, but characteristic of this lesion. Now, what makes this maybe a little bit distinctive is that over here next door, we've got some of it here, but we've also got this more dilated cystic space. And as we look at this area, we see that, lo and behold, this has a mucinous character. So we have a combined mucinous cystadenofibroma with a Brenner tumor, illustrating again that some of these lesions can have mixed epithelial cell types. These appear to be somewhat separate, so they might actually be two separate tumors colliding with one another. But in either event, both are benign and the behavior is going to be good. Now, what are the features you're going to look for to classify it as borderline? Those would be features where you have essentially a transitional carcinoma in situ type of lesion, but you don't have expansion or you don't have the beginnings of individual cell invasion. And that's the boundary between benign Brenner tumor, borderline Brenner tumor, and then between borderline Brenner tumor and malignant Brenner tumor, is seeing some measure of destructive stromal invasion that qualifies as an invasive malignancy. Here's another case. Again, we see a couple of things. We see these large cystic spaces with lamellated calcification, and then we see this tumor over here. So we'll focus here and say what we have here. We have more cystic formation here, but as we look, we also see these are, many of them are not particularly dilated, and it's not a mucinous type of epithelium or a serous epithelium. This is our friend, the transitional type of epithelium with just more prominent cystic spaces. Again, we can see a few nuclear grooves, very bland, low-grade nuclei that make this a benign entity. Now, these other lesions over here, what are these? Well, let's take a look. These appear to be a component of squamous epithelium, as you can see here, keratinization, attenuated squamous epithelium. So this could be one of two things. This could be a component of a malignant teratoma, or it could be a metaplastic change from an endometriotic cyst, more likely a true dermoid in the sense of not having other cell lines beyond the epidermal component. But worth considering and making sure you evaluate all of the features that you've got here. So an interesting combination of lesions in this ovary. So let's move on and talk about the clear cell tumors. Again, we have the similar categories: clear cell adenofibroma, borderline clear cell adenofibroma, and then clear cell carcinoma. These are sufficiently rare as to be a subject of papers in and of themselves that selected consultants may be able to assemble sufficient cases to give us a history of those. So don't expect to see one of these during your lifetime, but if you do, hopefully you'll be able to recognize it. Again, clear cell adenofibroma is also relatively uncommon, but do occur. And then clear cell carcinoma. Interestingly, we often see this as a mixed form of neoplasia in the ovary. So seeing a mixed component with clear cell and endometrioid or clear cell and serous is not to be ignored and should be quantitated if you find it. Of course, the clear cell phenotype that we might think of is NAPSN-A positive and P53 wild type, or HDMA positive as well in the clear cells. So let's take a look. Here's a typical presentation, a GI biopsy, and guess what? We have a metastatic carcinoma, and as we look and evaluate this neoplasm, we see that it has a little bit of hobnailing, a little bit of sort of cystic formation, very pale or clear cytoplasm, some prominent cytoplasmic borders, and so this actually turned to be a metastatic clear cell carcinoma from the ovary that had involved the GI tract. And sometimes that will be the presentation. You'll see it in a peritoneal biopsy, or you'll see it in a biopsy from another site. That should be retained in your differential. And very often in this location, or this type of a setting, it will recapitulate the appearance that you see in a primary lesion with hobnailing, clear cell, solid areas, pseudoacinar formation, and so forth. But in a more conventional setting, arising from the ovary, here's a representative section and partly necrotic tumor. And as we look at this, we see variably sized cystic spaces, variable cellularity, and as we go to higher magnification, a couple of features jump out at us. One is note the stromal hyalinization of these cores of these fibrous papillae. There's almost no identifiable vessel here because it's become so hyalinized in these areas. The second feature is to notice the high nuclear grade, generally a single layer of cells, and oftentimes an inverted polarity with an apical nucleus that sometimes produces what is called the hobnail cell, where the nucleus is at the apical end and the pointed cytoplasmic tip is attached to the fibrous stromal core. Typically, the nuclei are fairly high grade, and you may find mitoses with some frequency. Now, this is sort of the conventional sieve-like pattern. We can also see more solid types, and we can see variants where the cytoplasm is not so much clear as just pale eosinophilic. Here's a little bit more complex papillary pattern, as we see here, with more cells filling the pseudoacinar type space. And again, high-grade nuclei, easily identifiable nucleoli, and probably increased mitotic figures. If you search around in these areas, you will find areas where you find nice, clear cytoplasmic changes like you see here, but there'll be other areas where it will be more solid and eosinophilic. Here's another example. Again, this from an ovarian source, and we can see this nice clear cell pattern, very pale cytoplasm or almost non-existent cytoplasm with halos around the nuclei, a somewhat prominent nuclear cell membrane that shows up because of the clearing of the cytoplasm, and high-grade nuclei. So if you don't find hobnail cells, you can still call it clear cell carcinoma. If you don't find clear cytoplasm, you can still call it clear cell carcinoma, but you do want to make sure that your immunophenotype matches and that the clinical presentation and other features have been excluded, because you certainly don't want to mistake this for a different flavor of high-grade carcinoma. So that concludes our quick run through the endometrioid, the transitional, and the clear cell lesions, concluding part 3. And with that, we will bid adieu for today, but hope that you'll stay tuned and subscribe to our channel so that you can catch up on part 4, which will follow along at some point in the next few days. Thanks very much, and until next time, thanks for joining us.